Most people over 60 believe that when a surgeon looks them in the eye and recommends an operation, that's it. That's the answer. The doctor knows. You sign, you show up. You trust that someone in that room understands your body better than you do. I used to believe that too. I used to trust the surgical recommendation completely until I started counting what was happening to the patients who came back to my clinic afterward. Not better. Different. Carrying something nobody had warned them about. A woman in her late 60s agreed to bladder surgery. She came back dependent on a catheter nobody had prepared her for, managing infections that hadn't existed before she walked into that operating room. A man of 72 had an entire kidney removed for a mass on a scan. A year later, his remaining kidney was in decline, for a mass that studies now show could have been safely monitored instead. Here's what nobody tells you before you sign that consent form. My name is Dr. Sophie Martin. I'm a urologist with over 20 years in clinical practice, and today I'm going to tell you the truth about 5 bladder and kidney surgeries that carry serious risks for people over 60. Risks your surgeon may not have fully explained. 5 surgeries, the risks, and the alternatives that most patients are never told exist until it's too late to ask. Think about the plumbing in a house that was built 50 years ago. The pipes still work. The water still flows. But if you run that system under the same pressure you would a brand new build, force it through the same stress tests, the same sudden surges, something gives. Not because the system is broken, because the demands being placed on it were designed for something younger. Your body is no different. Here's what the consent form doesn't explain. The surgical protocols used on a 45-year-old are, in most cases, the same protocols applied to a body of 75. Same anesthesia calculations, same recovery expectations, same procedural thresholds. And your instinct that this seems wrong, that instinct is correct. Here is what actually happens to the urological system under surgical stress after 60. Kidney function declines naturally with age, and anesthesia compounds that decline in ways that don't fully reverse after the procedure ends. Bladder tissue becomes more fragile, slower to repair, less forgiving of surgical intervention. The immune response that protects you from post-operative infection grows slower and less predictable with every decade past 70. And then there is something called post-operative cognitive dysfunction, a measurable, documented decline in memory and mental clarity that follows major surgery, affecting nearly 1 in 4 patients over the age of 75. A study published in the Journal of Urology found that patients over 70 face complication rates nearly double those of younger patients undergoing equivalent urological procedures. And research from the American Geriatric Society found that more than 40% of adults over 75 carry frailty markers that significantly elevate surgical risk, markers that most pre-surgical assessments never formally screen for. Age alone is not the deciding factor. The real variable is frailty, your kidney reserve, your healing capacity, your body's ability to absorb and recover from surgical stress. And unlike your birth year, those variables are something we can actually measure, monitor, and in many cases, meaningfully improve. So let's talk about the 5 surgeries. And I want to be clear before we begin. Every procedure on this list can be the right choice for the right patient in the right circumstances. What I am asking you to question is not surgery itself. What I am asking you to question is whether you were given the full picture before you agreed to it. Overactive bladder affects tens of millions of seniors. When medications stop working, and for many people they eventually do, bladder augmentation is increasingly offered as the next step. In this procedure, a segment of your own bowel is used to enlarge the bladder. It sounds definitive. It sounds like a permanent fix to a problem that has controlled your life for years. But here's the truth. For seniors over 65, bladder augmentation carries consequences that are rarely explained in full before the consent is signed. The bowel segment used does not simply become bladder tissue. It continues producing mucus inside your bladder for the rest of your life. Patients must learn to self-catheterize permanently, and the metabolic interaction between bowel tissue and the bladder environment places significant stress on an aging system that was never designed to manage it. A study published in Neurology and Urodynamics found that elderly patients undergoing bladder augmentation face complication rates exceeding 40%, with metabolic and infectious complications disproportionately represented in patients over 65. Chronic mucus buildup follows. Recurrent urinary tract infections follow that. Metabolic acidosis, where the body's chemical balance is progressively disrupted, begins to place strain on the kidneys. And in patients who were already managing reduced kidney function before they walked into that operating room, the long-term decline can be significant. The alternative exists and it works. Sacral neuromodulation, a therapy called InterStim, uses a small implantable device to modulate the nerve signals driving overactive bladder. No bowel involvement. No permanent catheterization. Reversible if it needs to be adjusted. And increasingly effective in patients well into their 70s and 80s. Have you or someone you love ever been told that surgery was the only option left for bladder problems? Tell me in the comments. I read every single one. Now, a scan finds a mass on your kidney. That word, mass, is one of the most frightening words a doctor can say in an examination room. And the recommendation that follows, remove the entire kidney, feels like the only responsible answer. Of course you want it out. Of course you trust that the urgency is real, but here's what most patients are never told. Not every renal mass is an aggressive cancer requiring immediate radical surgery. A landmark study published in the New England Journal of Medicine found that small renal masses, those under 3 to 4 centimeters, in patients over 70, grow so slowly that active surveillance produces equivalent survival outcomes to immediate surgical removal. But radical nephrectomy takes an entire kidney. And in a senior whose kidney function has already declined with age, losing one kidney can be the event that tips the balance into chronic kidney disease. Loss of kidney reserve is the first consequence. Accelerated progression toward chronic kidney disease follows. Dialysis dependence becomes a real possibility. The cardiovascular system, already under strain, absorbs the additional pressure. And in frail patients, the data shows that death from surgical complications can come before death from the cancer itself ever would have. The alternative is active surveillance, regular imaging, careful monitoring, a protocol designed specifically for slow-growing masses in older patients. Where surgery is genuinely necessary, partial nephrectomy, removing only the tumor while preserving the kidney, is now the preferred approach at high-volume centers. The question to ask your surgeon is direct. Is this mass a candidate for surveillance or partial removal? Before today, had you ever heard that a kidney mass could be safely monitored rather than surgically removed? Most of my patients hadn't. And that gap in knowledge is exactly what this channel exists to close. Kidney stones are one of the most painful experiences a human body can produce. When a senior presents with a large or complex stone, the surgical recommendation feels entirely reasonable. The pain is real, the urgency is real, of course you want it removed. But here's what the standard conversation often leaves out. Open surgical removal of kidney stones and percutaneous nephrolithotomy, even in lower-risk cases, carries significantly elevated risk in seniors managing compromised kidney function or cardiovascular conditions. Yet these approaches are still recommended when less invasive options would work equally well. A study in the Journal of Endocrinology found that patients over 65 undergoing percutaneous nephrolithotomy face complication rates nearly twice those seen with minimally invasive alternatives, with bleeding, infection, and anesthesia exposure driving the majority of serious outcomes. Bleeding risk comes first, infection follows, prolonged anesthesia exposure compounds existing kidney stress. Acute kidney injury becomes a real and measurable outcome. And in patients already managing chronic kidney disease, the damage can be permanent. Ureteroscopy with laser lithotripsy removes kidney stones through a scope, no incision, no open surgery, dramatically reduced recovery time. Shockwave lithotripsy uses targeted sound waves to break stones apart from outside the body entirely. Both options exist. Both are appropriate for a wide range of stone types. Both carry a fraction of the surgical risk, and most seniors are never told they are available. Surgical mesh for pelvic organ prolapse and stress urinary incontinence has been offered to senior women for decades. It was presented as durable, effective, and routine. For years, the conversation around mesh implantation carried the confidence of established medicine. But here's what I see in my clinic every single week. Transvaginal mesh has been the subject of thousands of documented complication reports and significant regulatory action by the FDA. Action taken precisely because the failure rate in real patients did not match what had been promised. Mesh erosion, where the synthetic material gradually wears through the surrounding tissue, causes chronic pelvic pain, recurrent infection, and in severe cases, fistula formation. Revision surgery to address mesh erosion is consistently more complex and more dangerous than the original implantation. And in senior women with thinner, more fragile pelvic tissue, the erosion risk is substantially higher than in younger patients. FDA safety communications documented thousands of adverse event reports related to transvaginal mesh, with erosion and organ perforation listed as the most frequently reported serious complications. A study in the American Journal of Obstetrics and Gynecology found mesh erosion rates in women over 65 significantly exceeding those reported in younger surgical populations. Mesh erosion is the entry point. Chronic pelvic pain follows and frequently does not resolve. Recurrent urinary tract infections become part of daily life. Fistula formation, abnormal connections between organs, represents the severe end of the cascade. Revision surgery carries a higher complication rate than the original procedure. And for frail seniors, the cumulative impact on quality of life can be permanent and irreversible. Native tissue repair uses your own biological material, no synthetic implant, no erosion risk. Pessary devices offer a non-surgical, removable, highly effective option for prolapse management in appropriate candidates. Pelvic floor physical therapy, pursued seriously before any surgical decision is made, produces meaningful improvement in a significant percentage of women who were told surgery was their only path forward. Now we come to the fifth surgery, and this one requires the most careful conversation of all. A bladder cancer diagnosis or severe treatment-resistant bladder dysfunction can lead to a recommendation for radical cystectomy. Complete removal of the bladder. It is presented as necessary. Life-saving, the only option left on the table. But here's what the brochure doesn't prepare you for. Radical cystectomy is one of the most physically and psychologically transforming surgeries a senior can undergo. Life without a bladder requires either a urostomy, a permanent external collection bag, or a neobladder constructed from bowel tissue, which carries its own serious long-term management demands. For seniors over 70 with significant comorbidities, the surgical mortality rate is not a footnote, it is a number that must be clearly communicated and genuinely understood before any consent is given. And for certain bladder cancer profiles, bladder-preserving trimodality therapy, combining targeted surgical resection, radiation, and chemotherapy, produces comparable survival outcomes without removing the organ entirely. A study published in the Journal of Clinical Oncology found that carefully selected elderly patients treated with trimodality bladder preservation achieved 5-year survival outcomes equivalent to those seen with radical cystectomy, with significantly lower rates of surgical mortality and major complication. Surgical mortality risk in frail seniors is the first reality to understand. Bowel complications from neobladder construction represent a second major risk category. Metabolic imbalances from the reconstruction follow. The psychological impact of permanent urostomy, something surgeons rarely spend enough time discussing, is profound and lasting. And for patients managing multiple comorbidities, the inability to complete planned recovery can leave them in a worse functional state than the disease itself. Trimodality therapy, TURBT, combined with radiation and chemotherapy, is an established, evidence-backed alternative for appropriate bladder cancer profiles. A thorough pre-surgical frailty assessment, conducted before any radical procedure is scheduled, is not optional. It is the standard of care that every senior deserves. And evaluation at a high-volume center, where surgeons perform these procedures regularly and outcomes data is tracked rigorously, can be the difference between a recommendation that fits your specific situation and one that fits the average patient on paper. Before you, or anyone you love, agrees to any of these surgeries, write these questions down. These are the exact questions I wish every patient had asked before signing anything. And I want you to notice something as you hear them. None of these questions are aggressive. None of them are confrontational. Every single one of them is your right. What is my specific complication risk for this procedure? Not the average patient's risk, but mine, based on my age, my kidney function, and the other conditions I am managing. The brochure gives you population averages. What you need is your number. Is there a less invasive alternative to this surgery that is appropriate for my specific case? And if there isn't, I want to understand exactly why not. Not a general answer. A specific one that accounts for my history, my anatomy, and my age. What happens if I choose watchful waiting or medical management instead of surgery? What does that path actually look like for someone my age with my health profile over the next 6 to 12 months? What does realistic recovery look like for someone my age? Not the brochure version, but what I should genuinely expect in the first 30, 60, and 90 days. Who will be managing my care during that window? What complications should I be watching for? And the fifth question is the one that tells you everything you need to know about the surgeon sitting across from you. Ask them directly, what is your personal complication rate for this procedure in patients over 70? A surgeon who performs this regularly will know that number without hesitation. If the question makes them uncomfortable, that discomfort is information, and it is information you are entitled to have. These questions do not make you a difficult patient. They make you an informed one. And informed patients, every study that has looked at this confirms it, have measurably better outcomes than patients who trusted without asking. That was a lot to absorb. 5 warnings. 5 surgeries that carry risks most seniors are never fully told about before they sign. And I understand if what you're feeling right now is something close to overwhelmed, but I need you to hear this clearly. The last 15 years have produced a genuine revolution in minimally invasive urology, and most patients have no idea it has happened. Robotic-assisted laparoscopic surgery has dramatically reduced recovery time for procedures that once required weeks of hospitalization. Laser lithotripsy has eliminated the need for open stone surgery in the vast majority of cases. Sacral neuromodulation has transformed overactive bladder treatment for seniors who were once told that major surgery was their only remaining option. And focal therapy for kidney masses is now replacing radical removal in patient profiles where, a decade ago, the entire organ would have been taken without question. The urinary system, even at 70, even at 80, is more resilient than most people are told. It responds, it heals, it adapts. When we stop subjecting it to interventions it doesn't need and start giving it the precise, targeted care it does need, the results can be genuinely remarkable. Sometimes the most powerful thing I can offer a patient is not a surgical referral. It is an honest conversation about whether surgery is actually necessary at all. I want to tell you about Margaret. She was 73 years old when she came to see me. She had a garden she tended every morning before breakfast. Dahlias, she told me, rows of them. And a granddaughter she walked to school 3 days a week. She was not a woman who sat still. She was not a woman who thought of herself as someone who needed to be taken care of. She had been diagnosed with a bladder condition that her previous doctor had determined required surgical mesh implantation. She was told it was the standard approach. She was told it was routine. She came very close to signing. What changed was a single question. One of her daughters had watched a video, not unlike this one, and had written something down. Margaret came into my office and asked me directly, "Are there other options that don't involve a permanent implant?" That question opened a conversation that changed everything for her. What Margaret had told her previous doctor, the line that has stayed with me, was this. Softly, "I don't want my family to stop seeing me as me." 15 words. No medical language. Everything that mattered. She was a candidate for native tissue repair, no synthetic mesh, no erosion risk. A longer recovery than she would have liked, but a full one. The last time I saw Margaret, she told me the dahlias had come back thicker than ever, and her granddaughter was still waiting at the door every Tuesday and Thursday morning. A surgical recommendation is not a verdict. It is the opening offer in a conversation that you have every right to continue. That consent form sitting on the table in front of you, the one with the signature line at the bottom, or is not the finish line. It is a question, and you are allowed to answer it slowly. You are allowed to ask what it does not explain. You are allowed to hand it back and say, "Not yet. Tell me more," with conviction. The scalpel belongs to the surgeon. The kidney function panel, the scan result, the signature, those belong to you. And no degree on any wall changes that. You have the right to ask. You have the right to wait. You have the right to seek another voice before you decide. You have the right to walk out of that room with your questions still open, no, and come back only when you are ready. That is not resistance. That is medicine. Practice the way it was always meant to be. So let's bring it together. Bladder augmentation for overactive bladder carries lifelong management demands and serious metabolic risk. And sacral neuromodulation now offers a minimally invasive alternative that works. Radical nephrectomy for small renal masses may be removing kidneys that never needed to come out. Active surveillance and partial removal are options worth demanding. Open kidney stone surgery carries risks in seniors that ureteroscopy and laser lithotripsy make entirely avoidable. Surgical mesh for pelvic organ prolapse has harmed thousands of women who were never warned. Native tissue repair and pessary devices exist, and they work. And radical cystectomy, without exhausting every alternative first, may be the most consequential decision a senior can make. Tri-modality therapy has produced equivalent survival outcomes for appropriate candidates. Which of these 5 surgeries surprised you most? And have you or someone you love ever been recommended one of them? Tell me in the comments. Your experience might be exactly what someone else needs to read today. If this video made you stop and think, or if someone came to mind while you were watching, share it with them. You don't need to say a word. Just send it. That one share might be the most important thing you do for someone you love today. Take care of yourselves. You deserve a urologist who explains everything, a surgeon who welcomes your questions, and the knowledge to walk into any appointment knowing exactly what to ask. Everything I've shared today is based on published clinical research and more than 20 years of patient care. But it is general information, not personal medical advice. Your history, your kidney function, your specific conditions, those matter enormously, and I don't know them. Please bring what you've learned today into a full, honest conversation with your own doctor or specialist. That conversation, informed, direct, and unhurried, is exactly where good medicine begins.